Get ready for an experience you will never forget. These are 5 reasons you must attend the APPSDPRC 2025 in Bangkok, Thailand from April 1st to 4th. Reason 1. Premier Congress in Pediatric Pulmonology in Asia. This is Asia's leading congress in pediatric respiratory, critical care, and sleep medicine, hosted by APPS and TPRC. APPS has 22 member countries. It's your excellent chance to connect with the best in the field. Reason 2. Inspiring speakers and comprehensive program. Learn from renowned speakers coming from 18 countries. Attend 3 keynote lectures, 8 expert sessions, 20 symposiums, and from many symposiums designed to inspire and elevate your practice. Reason 3. Exclusive hands-on workshops. Dive into 2 pre-congress workshops and 10 complimentary workshops in the main congress, offering hands-on learning opportunities. Seats are limited. Don't miss your chance. Reason 4. Opportunities for recognition and awards. Submit your research abstracts to compete for the Young Investigator Awards and the prestigious APPS Young Fellowship Award. Reason 5. Explore Bangkok and enjoy Thai hospitality. Discover the rich culture of Bangkok, conveniently located at the Eastern Grand Hotel Phaya Thai. Our venue is easily accessible and offers world-class amenities, including an international buffet at the Market Restaurant. Don't wait, mark your calendar for APPSDPRC 2025, April 1st to 4th in Bangkok. Visit our website for details and registration. We'll see you there. Looking forward to welcoming you in Bangkok.
My name is Arunwan Pritipan. I am the president of the Asian Pediatric Pulmonology Society. As you may know, Thailand will host an international conference in Bangkok this April. We are excited to welcome you to our renowned Thai hospitality. With strong collaboration from our member countries, we have successfully conducted the grand round for over a year, and today marks the 8th session. The moderator, presenters, and panelists have worked diligently to provide our audience with practical knowledge of pediatric respiratory diseases. I want to extend my sincere gratitude to Dr. Daniel Ng from Hong Kong, the founding president of the Asian Pediatric Pulmonology Society, for his hard work, time, and efforts as a producer behind the scenes of each grand round. I also want to thank Professor Shakil Ahmed from Bangladesh for his closing remarks. We will conclude our case discussion within an hour, followed by an additional 15 minutes to address questions from the audience in the chat. Please take a moment to provide suggestions for improving the grand round in our evaluation form. For those who would like to receive a certificate of attendance, kindly fill out the form and we will send it to you via email. Thanks to the Vietnam Respiratory Society for co-hosting this grand round. We are pleased to announce that our moderator today will be Professor Phan Hua Wei Yin, She is a senior lecturer at the Department of Pediatrics at the University of Medicine and Pharmacy in Ho Chi Minh City. She is also the former head of the General Internal Medicine and Respiratory Department at Children's Hospital and an executive committee member of Vietnam Respiratory Society, Ho Chi Minh City Respiratory Society, and Vietnam Pediatric Association. So, please join me in welcoming Professor Phan Hua Wei Yin. Thank you.
Thank you very much, Professor Arawan Pratiban. Good evening, everybody. Tonight's topic is recurrent respiratory distress and iron deficiency, anemia in a toddler. Let me introduce tonight's panelists. First, we have Professor Anna Nathan. She is a senior consultant pediatrician and pediatric pulmonologist at the University of Malaya, Kuala Lumpur, Malaysia. Our second panelist is Professor Yao Yao. She's an associate consultant pediatrician and pediatric pulmonologist at Beijing Children's Hospital, Capital Medical University, China. Our third panelist is Professor Sami Anhaider. He is a consultant pediatric pulmonologist at King Faisal Specialist Hospital and Research Center, and an adjunct professor pediatrics at FSO University, Riyadh, Saudi Arabia. Our presenter tonight is Dr. Hồ Thiên Hương. She is a pediatric pulmonologist in international sleep specialist at the Respiratory Department, Children's Hospital 1, Ho Chi Minh City, Vietnam. May now I invite Dr. Hồ Thiên Hương to present the case. Dr. Hồ Thiên Hương, please.
Good evening, doctors. I will present a very interesting case today. This is the 21st month old. She was born in Quảng Bình, Vietnam. Next slide. And she admitted to the hospital with the chief complaint of the pale skin and loss of appetite. Next slide. The history of the recent illness. When she was infancy, she was a full-term vaginal birth, and under 6 months, she was the breastfeeding. However, from the 6th to the 12th month, she changed into the regular formula 8 times a day and with the once whole of the period. Next slide. Next slide. From the 2012 to the 21, she changed into the Maisie Toddler formula 8 and 10 times a day. And you can see that the Maisie Toddler formula was the main diet for the kids. And she already used only 1 or 2 small points of the burette or the porridge. Next slide. Next slide. Yeah. And now, when she was 21 months, the parents they saw that the baby presented with a pale skin, loss of appetite, no vomiting, no diarrhea, no coughing. And they transfer her to the Rovins Hospital. At the Rovins Hospital, the clinicians give her the CBC. And we can see in the CBC, the hemoglobin was only the 6.3. And in the peripheral smearing, the myocytic hypochromic anemia. And they're screening for the main cause of the anemia at that time. And hemoglobin electrophoresis was normal. And all serum iron and ferritin decreased. So at that time, at the Rovins Hospital, they suspected of the moderate iron deficiency anemia, and the reason course is the inadequate iron intake. And at that time, the treatment was the oral iron supplement for 3 months. Next slide. Yeah, and after 3 months of treatment of the oral iron supplements, the kids presented with a good appearance, no other abnormal symptoms, and at the CBC, it was normal. The hemoglobin increased from 7 to the 11, and the serum iron and the ferritin turned into normal. And at that moment, the clinician decided to stop using the oral iron supplements for the kids. Next slide. Next slide. Yeah. However, and no other symptoms. And the parents decided to transfer to another hospital. And these were the transfusion and hematology hospital. We can see that this is the raw data of the patient. From the 12 to until now, the raw data became flattened and below 10%. Next slide. At the transfusion and hematology hospital, the patient had a history of the time of the of the oral iron deficiency anemia, and now she just returned again with anemia. So at the CBC, we can see the hemoglobin returns only very low. It's only the 4, and in the peripheral blood smear, and it appear again the myelocytic hypochromic anemia, and the serum iron and ferritin decrease. At the transfusion hospital, the clinician didn't believe the iron, the cause of the iron deficiency anemia was in appropriate iron intake in her diet. So they searched for the other causes, and come test negative, the liver and the kidney function was normal. And of course, the ochre blood normal, negative, in the urine normal, and they search for the malabsorption in this patient, and the B12 acyclic was normal. The other causes such as immunocompromised disorder or the autoimmune disorder was screening, and they are normal too. And vasculitic was normal. At that moment, the clinician diagnosed the patient with the severe iron deficiency anemia with the normal iron intake. Next slide. So at that moment, the treatment, because the little girl just had a very low hemoglobin at that moment, so the emergency blood transfusion were required, and it increased hemoglobin from 4 into 10 at that moment, and they also keep giving the patient the oral iron supplement again. However, after 7 days after admission, the little girl presented another symptom of the respiratory tract. She presented with the wet cough, and the respiratory rate were 55, the chest retraction, and the SpO2 within the room air is only the 89%, no rare. At that moment, the clinician noticed that the patient just had a pale skin again. So the CBC were did again, and the hemoglobin from 10 return into only 7. Next slide. And especially, next slide. And especially because the baby began to have the respiratory symptom, the wet cough. So in the chest X-ray, we can see the consolidation in both lungs, but in the right lung is dominant. And also see air bronchiogram visible through the cardiac shadow and the ground glass of pacification in both lungs. So at that moment, the treatment was the oxygen cannula, the ceftriaxone injection, and they decided to transfer the patient into the Children's Hospital 1, Ho Chi Minh City. Next slide. So at the Children's Hospital 1, we can see the patient, the physical examination, see how the respiratory stress, the SpO2 at the room air is only 89%, no finger clapping. The respiratory rate is 55, and the crackle and the bow lunge, the bilateral and expiration wheeze, and the pale skin. Next slide. So, because in the chest X-ray at the transfusion hematology hospital, we can see the round blast opacification in the both lung and some consolidation. So at the Children's Hospital 1, we decided to give the XRCT. And surprisingly, on the XRCT, we can see the crowd glass opacification in the both lungs. So we can see at that moment suspected of the interstitial pneumonia. So what is the cause of the little girl with the twice of the blood transfusion and the severe iron deficiency anemia and the ground glass opacification in the lungs? So what is the diagnosis at that moment we suspected of? Next slide. We try to find the main cause of this lesion in a RCT. We search for the other causes, and we believe that the iron deficiency and lesion in the RCT has the correlation. So we search for some main causes such as the autoimmune disorders, the vasculitis, the anti-GBM of the Goose factor, and they were normal. The primary and the secondary immunocompromised disorder negative too. In Vietnam, the tuberculosis was a common pathogen. It can cause some lesion in the RCT. So we screening for the Mycobacterium tuberculosis in the gastric fluid, and they are negative too. The stone form in the occur blood negative, and the B12 and acidic normal. However, because in the RCT, we can see the lesions look like the diffuse alveolar hemorrhage. So we didn't know that there is the correlation between the iron deficiency anemia and the lesions in the RCT. So we search for the blood in the gastric fluid, and the hemosiderin-laden macrophage in gastric fluid was described and is positive. And this can because under the patients didn't have the hypothesis at her symptoms. However, because only the 21 months old, so we think that she swallowed her mucus, she couldn't expectorate the mucus. So the hemosiderin-laden macrophage in the gastric fluid was positive. We suspected because she just swallowed the mucus. Next slide. Next slide. Yeah. So at that moment, we can see the main symptom of the patient. The patient had the severe anemia, the lost transfusion twice in only 6 months, and the iron deficiency anemia. And in her diet, we saw that this was a normal iron intake, no evidence of blood loss from digestive and urinary system, no autoimmune disorder, immunocompromised disorder or vasculitis, and the weight gain slow and the flattened flow curve. On the RCT, we see the lesion, the image of the diffuse alveolar hemorrhage, and also the hemosiderin-laden macrophage in the gastric fluid was noted. So at that moment, we can conclusion the patient had the pulmonary hemosiderosis, but these were primary or secondary. At that moment, we think maybe the secondary can excluded because the evidence of the autoimmune disorder or immunocompromised disorder. But the primary or secondary, we need to go some further lab test. Next slide. So the patients had the hemosiderin-laden macrophage in her gastric fluid, but the kid didn't have any symptom from her digestive system. So we suspected that she couldn't expectorate the mucus. She swallowed it again, so we can detect it in the gastric fluid. So if we want to have the accurate diagnosis, we should implement the bronchoscopy. So this is the PAL. We can see the color of the PAL. This is the red. So this is the hemorrhage fluid. And we also do the PCR multiless to detect some pathogen in the PAL of the patients to exclude some infection or the tuberculosis, and they are negative for the pathogens. However, the hemosiderin-laden macrophage were positive, and during the lab test, we also prescribed a PER scan to detect the iron. So it's also positive too. Next slide. And we suspected the patients have the blood loss from her lungs. So we want to have the gold standard of the diagnosis. So the thoracoscopic lung biopsy were implemented in this patient. We can see this is the 4 figures of the patients, but in the figure 1, we can see there are numerous the hemosiderin-laden macrophage and erythrocyte in the alveolar spaces. And in the figure 4, with the bird standing to detect the iron, we see the numerous hemosiderin-laden macrophage in the alveolar spaces again. And in the figure 3, when we do the trichrome standing to detect the fibrosis, and we can see in this patient they have the interalveolar septal thickening and fibrosis. Next slide. So after all of the clinical symptoms and the lab tests and the thoracoscopic lens biopsy, so the most likely diagnosis in this patient, one, the idiopathic pulmonary capillaritis, B, the idiopathic pulmonary hemosiderosis, C, acute idiopathic pulmonary hemorrhage of infancy, and D, Bush-Pasteur syndrome with Olliland involvement. So next slide, we share the results. Yeah.
Okay, hi, thanks, Doctor. So this is Anna here from Malaysia. So let's just go over the poll results here. So I can see that many of you all have chosen idiopathic pulmonary hemosiderosis. Some of you all have chosen acute idiopathic pulmonary hemorrhage of infancy, although this child is actually beyond the infancy age. And there's a bit of a capillaritis in good pastures. So anyway, let me just go through the what I'm going to go through today, which would be the management or the approach of pulmonary hemorrhage. So firstly, it's very important to differentiate between whether or not the cause for the pulmonary hemorrhage is actually a focal or a diffuse hemorrhage. And as you can see, under focal hemorrhage, there are many, many causes, of which the common things being common, like infection, and especially TB, bronchiectasis, or congenital lung malformations, or even possibly trauma. But when one is handling a diffuse alveolar hemorrhage, that can be a little bit more complicating. Diffuse alveolar hemorrhage is divided into immune-mediated or non-immune-mediated. And under immune-mediated, you can see the barrage of vasculitic diseases here, the common ones being good pastures and Wegener's, and the more rarer ones, like some of you all chose, the idiopathic pulmonary capillaritis. When we come to the non-immune mediated, you can see that idiopathic pulmonary hemosiderosis is actually the top of the list. Next comes the acute idiopathic pulmonary hemorrhage of infancy, where only a few disorders are recognized as causes of hemorrhage in infancy. Coagulation disorders, asphyxia, and even fungal infections. We also see Heiner syndrome, a very rare disorder associated with cow's milk allergy. And last but not least, one must not forget the heart. And you can see that there are many causes, congenital causes of especially vascular disorders associated with the heart that can be associated with diffuse alveolar hemorrhage. Next slide. Can I control? Yes. So in this child, the CT actually shows that there's diffuse hemorrhage on both sides, but you can see that the hemorrhage is actually more on the right side compared to the left. But nonetheless, the CT is actually useful in differentiating between whether it's a diffuse or a focal hemorrhage. Next slide. Thank you. So as pulmonologists, we are all very familiar with the use of bronchoscopy. So when should we actually perform bronchoscopy? People say that you can perform a bronchoscopy as an elective procedure if it's a small bleed. And you can even perform it as an urgent procedure if it is a large bleed, because we believe that we can actually help to improve a significant alveolar mismatch or VQ mismatch. When we do bronchoscopy, we should be looking at any possible sites of bleeding, looking for abnormal mucosa, dilated blood vessels, and even any masses. You would flush with saline, because what is important is that if you notice that there's more blood coming as you flush, this is actually very diagnostic of diffuse alveolar hemorrhage. And bronchoscopy also can be therapeutic. as using cold saline can help to dampen down the bleeding, use of diluted adrenaline, and even tranexamic acid, which I'll talk a little bit about later. Finally, not to forget that it's not only about sending the hemosiderin-laden macrophages, which would be help to make the diagnosis of pulmonary hemosiderosis or pulmonary hemorrhage, but also excluding infection is imperative, because that again is one of the top things that we should be thinking of before we jump into the other more complex causes of pulmonary hemorrhage. Next slide. So here I just present about 2 slides talking about tranexamic acid. Although this is a case series in adults, next, you can actually see that in these cases, even though there are a variety of problems, whether it's cancer or etc., the use of tranexamic acid, whether instilled during bronchoscopy or by inhalation, actually helped in managing the pulmonary hemorrhage. Next slide. And in a double-blind randomized control trial, again in adults, but nonetheless, some things that we can learn about, when they use nebulized tranexamic acid at 500 milligram TDS, they found that there was a significant reduction in expectorant blood even as early as day 2 of admission, and they found that there was reduced duration of admission as well as a reduced recurrence rate. So hence the use of nebulized or inhaled tranexamic acid might be something that we might be able to use to help to manage our patients. Next slide. So let me go into what is idiopathic pulmonary hemosiderosis. It is defined by this triad: iron deficiency, anemia marked by a high reticulocyte count, hemoptysis, if you're lucky to get in children, and of course chest x-ray infiltrates. And IPH can be as high as 20 to 30% of cases or as identified as a cause for pulmonary hemorrhage. However, one must remember that this is a diagnosis of exclusion. Again, simple things being simple, you must exclude infection, any bleeding disorders, cardiac, etc. And it seems to be quite common in children with Down syndrome. Next slide. So infection again, and you can see that even viruses like adenovirus, bacteria like leptospirosis, fungus infections, and even others should be considered when you want to exclude infections. Next slide. So unfortunately for IPH, before you diagnose again IPH, again I stress that it's a diagnosis of exclusion, there's a whole barrage of tests that you need to do. So perhaps the first test or first line test should be looking out for infection, especially TB, looking out for blood disorders, and especially cardiac disorders. And don't forget to do the bubble test when you're ordering an echocardiogram. If these are negative, then one may progress to do the immune-mediated test. And under immune-mediated tests, besides just doing urine analysis to look for blood in the urine, don't forget to do your immunoglobulins. You may consider looking for Heine syndrome. You may think about celiac disease in somebody who has been weaned. We obviously will be looking at all the normal connective tissue disorders, serology. And lung biopsy may be something that we actually consider as the further below the line of test, because lung biopsy can be a little bit more complicating. Next slide, please. Next. So we know that now, as you can see from the case, that hemosiderin-laden macrophages in the BAL is highly suggestive of pulmonary hemosiderosis. And some people do suggest that the lung biopsy is a definitive test, whereby one only shows intra-alveolar hemorrhage and blood in the alveoli without the presence of any form of inflammation like capillaritis and cellular inflammation. Fortunately, IPH is corticosteroid responsive, although it can relapse. Next slide. So like in this patient, what we discussed earlier on, you can see that there's actually no signs of inflammation to suggest any form of autoimmune disease or capillaritis. Next slide. Finally, let's talk about lung biopsy, because lung biopsy in many studies shows that even in cases of IPH, only about 20% of these children actually undergo a lung biopsy. So when should you do a lung biopsy? Even though you may suspect a case of IPH, but if you suspect that you have perhaps a false negative connective tissue markers, one may go straight to do a lung biopsy. If you have a female, or perhaps the patient is not really responding to your first-line immunomodulators like steroids, or a recurrent and relapsing disease, one should perhaps really consider to do a lung biopsy in these children. Next slide. So let me conclude by summarizing this case, whereby here we have a child who presented with a triad of a pulmonary hemocirrhosis. It was confirmed by bronchoalveolar lavage. And the managing team did an excellent job of excluding the common things that could cause his pulmonary hemorrhage, including all the immune causes. And hence, since everything seems to be negative, our provisional diagnosis at this time is actually idiopathic pulmonary hemocirrhosis. So I pass over the floor. Am I right? Oh, yeah. Okay, next slide. Yeah, fist. Yeah, so this is an article which we wrote, and perhaps you can also take a read of it if you want to know more about how to approach pulmonary hemorrhage. Next slide. So I'm going to pass the floor over to Dr. Ho. Thank you.
Yeah.
Dr. Huang?
Next slide, please. Yeah. We return basic course, and after we had the resume the annual treatment in this patient, we combine between corticoid and the other immunosuppression because the patient just respiration to give the patient the corticoid injection is combined with the azathioprine. The oral high doses, it's a 2 milligram in the 2 weeks. And we also combine with the gluten-free diet. As in some textbooks, they just free because they some celiac disease with the weeks at patient to have gluten-free two twice of the corticoid and immunoimpressions and gluten-free diet. We decide to taper the regularly of the corticoid every 2 weeks and still combine with the azathioprine. Next slide. And we can see after 6 months of the corticoid and azathioprine and gluten-free diet, and on the left side was the XRCT at admission, and on the right side will be the XRCT after 6 months. We can see that the lesion in the both, just the baby just have some improved. However, it's just only below the 50% of the lesions in the both in the XRCT, and between the 6 months during the 6 months of treatment, the little girl just had the two recurrent episodes. Despite with continued immunosuppression, and we see the CT scan will show the round blast appearance. Next slide. So what further tests for this core of the apparent IPH in this patient? A. Endobronchial biopsy. B. V&V scan. C. Calmia specific EGG. And D. MRI angiogram.
Okay, The time is up. Okay, let's go through the result of the part 2 first. While most of you choose A, endobronchial biopsy, that's very interesting question. And let's go move on to the next stage and we will get the real answer. Okay. All right. So what is the clinical presentation suggestive of an alternative diagnosis? And you know that when the patient with IPH had the unsatisfactory response to the first line medication, we should do re-evaluation. To identify the underlying cause of DAH, we should obey step-by-step principle. So let's come back to clinical presentation firstly. So including the clinical presentation should including the age of onset, family history, exposure, symptoms and signs. So for this patient, the summary of this patient showed infant onset, and the onset is at 21st month, and the patient had pulmonary symptoms with no accompanying symptoms or signs like rash, nodules, arthritis, cutis laxa, clubbing, angiotelectasis, etc. So, which indicate CTD, EDS, hereditary metabolism disorders, or vascular malformation. And we noticed that the patient had recurrent episode with respiratory distress syndrome and iron deficiency anemia with no hemoptysis, which usually occur in the patient with focal hemorrhage, which is associated with vascular malformation due to the blood from high pressure system bronchial artery. And there is no de novo manifestations. And the only information could be checked is that the poor response to corticosteroid and the immunosuppressor. So the next one. Okay, so before we talk about the cause of the pulmonary hemorrhage according to age group, and we should focus on the radiography. And that is the second step. So we can check the manifestation, whether there's still the same sunset or it changed. We could see it is focal or diffuse or paving stone, or you can see remarkable septal lines or enlarged pulmonary arteries. And of course, we should confirm the infiltrations with accordance with anemia. And these characteristics can be the clues for some certain disorder, like cardiovascular malformation, pulmonary edema, infections, potential pulmonary hypertension. Since we had a patient with methylmalonic aciduria who presented as DAH onset, the chest CT scan showed subpleural GGO, enlarged pulmonary arteries and mild septal lines, which indicate the probability of PVOD, which guide me to think some disorder that involved with vessels. So double check the result of the CT scan is very crucial. For this patient, and still have GGO at recurrent and no other etiology suspected from radiology. So, well, let's come to the common cause of pulmonary hemorrhage according to age group. So what should we do next? And we look up the paper and we find the age could be one of the clues. Here is the cause of DAH according to age. And this table shows the different groups in newborn, infant, school age, and adolescent. So do you guys remember that the information about the evaluation of clinical presentation of this patient? The age of onset is 21st in this patient. So focus on this part. Okay, so focus on this part. It shows that the bronchial cyst and IPH and the Hainer syndrome, infection, coagulation should be candidate. But actually, we face more complicated problem in clinic. These diseases are too limited, DAH usually is clinical manifestation of various underlying conditions. For example, methylmalonic aciduria, some monogenetic disorder like COPA, SAVI, or as a company disorder, which is genetic susceptibility. So what's the next step? To redefine the etiology of DAH. So the next one, okay. Thank you. Then let's review the classification of DAH that Dr. Anna talked about previously. The categories of the DAH are not clear due to the ambitious mechanism. Here, there are two main groups. One is idiopathic, another is secondary. And some papers are inclined to pick allergic reaction out of one item. But for this patient, many tests were performed according to the flow that Dr. Anna has already elaborated. Then I would give a supplement basis on the initial investigations called coagulation disorder, autoimmune disorder, immunocompromised disorder, vasculitis, and celiac disease were ruled out. But there is lack of so the test about cow milk allergy should be ordered. Besides, from our experience, and serum homocysteine, celiac, HLA susceptibility, and whole exome sequencing might be recommended to exclude methodology, aciduria, celiac disease, monogenetic disorder, and then surgical biopsy. And we talk about surgical biopsy should be considered after many times re-evaluation, but this patient have already done the surgical biopsy. Just like Dr. Anna talked, if this diagnosed the Hainer or something like that, and but they should do the surgical biopsy. But in my opinion, and the biopsy is very important to rule out other conditions if there's unclear IPH. So we can rule out the vasculitis and the malformation and PCH. And for this patient, we would arrange the immune histochemical stain for cow milk IgG4 and the immune complex to find out the exact evidence. And all right, so this is my section, and next one. Okay. So what is the most likely diagnosis? The first one is Hainer syndrome, and the second one is Goodpasture syndrome, and third one is idiopathic pulmonary capillaritis, and the last one is pulmonary renal occlusive disease.
Okay. Thank you, Professor Dr. Yao Yao. So we can see in the bottom three with the questions, what is the most likely diagnosis? Most of you choose the Hainer syndrome, and others choose the idiopathic pulmonary capillaritis. So we will take a look at some slides to see what the exact diagnosis in this patient. Next slide, please. Okay, so in this patient, when we, after 6 months of using the two kinds of the corticoid immunodescription and the gluten-free diet, we saw that the patient just showed a very bad response with the common treatment. So we suspected of this other diagnosis that mimic the IBX symptoms. So in some textbook, they just mentioned about the gluten-free diet because in their country, some patients have the allergy with the wheat. So we usually call it the celiac disease. So in fact, in Vietnam, our patient didn't have too much allergy with the wheat, usually with the cow milk. And we suspected maybe the allergy with the cow milk can be the appropriate diagnosis in this patient. So we think about the Hainer syndrome. We also give the patient the skin prick test for the cow milk, and it showed normal. Maybe it's right because the Hainer syndrome means the delay or the late cow milk allergy. So EGE will be negative. And we already screening for the specific EGE with the cow milk, and the result was normal. However, with the specific EGG4 with the 3 kinds of the protein of the cow milk, the alpha-lactolobulin, the beta-lactolobulin, and casein, all of them was positive, and ECG was strongly positive. And we also do the serological markers for the celiac disease to screening for the wheat allergy. However, they were negative too. So in this patient with the symptom mimic the IPH and EGG with the cow milk protein was positive. So we suspected of the patients with the Hainer syndrome. Next slide. So we diagnosed the Rappaport-Hainer syndrome at that moment. Next slide. Okay, so after 6 months of diagnosis of the IPH, we changed into the Rappaport-Hainer syndrome, and we can see this is the chest X-ray of the patients when she was 6 months. After 6 months of the treatment, she just started with the pale skin. In the CBC, the hemoglobin was only 7. Although we give the patient 2 kinds of the treatment of the corticoid and immunodescription, and also graph blast specification in the both lung. So at that moment, when we suspected of the Hainer syndrome, we also give the patient the corticoid, and we ask the patient to avoid the cow milk in her diet. Next slide. After 2 weeks of the corticoid with the high dose and the cow milk avoidance, we decided to give the patient a high dose again because in the chest X-ray and also in the CBC and HRCT, the patient still have the symptom, the anemia, and also have the opacification in the both lung. After 2 weeks, we can see in the CBC, the hemoglobin from 7.5 increased into the 8.5. And the chest X-ray after 2 weeks, we see this is decreased infiltration in the both lungs. So we decided to taper the corticoid into low dose and change from the cow milk into the soya milk in this patient. Next slide. We can see this in the flow to diagnose the Hainer syndrome. If we want to diagnose the Hainer syndrome, besides of the symptoms, the pulmonary symptom and the chest X-ray infiltration, we should have the B. This is the restoration after the meal removal. In this patient, we have A, the symptom, the chest X-ray, and when we avoid the cow milk, the chest X-ray, the CBC return normal. So we at that moment we can jump into the diagnosis of the Rappaport-Hainer syndrome. If we want to diagnose the patient with the convincing Hainer syndrome, we should have the GLU-C. That means recurrence after meal reintroduction. But in fact, we never ask the patient to re-intake the cow milk at that moment again when we suspected of the Hainer syndrome. Because when we want to have the convincing Hainer syndrome, ask the patient to use or to drink the cow milk again, the patients can have they jump into the acute respiratory distress, and it's very dangerous for the patient. So at that moment, we can stop at that stage, the Rappaport-Hainer syndrome. Next slide. However, the next slide. After 5 days, when we taper, we decrease the dose of the corticoid into from 2 to 1.5. The little kids, they extremely want to eat the yogurt, and the parents give her only 5 teaspoons of the cow milk yogurt and 2 pickles. And 1 day later, she sent it again with the bare skin, and she admitted to the emergency department, respiratory department. At that moment, we checked the CBC, and the hemoglobin decreased. And we asked only the day, the previous day, the kids have the cow milk yogurt and 2 pickles. So the CBC hemoglobin decreased again, and the bare skin and the respiratory distress and SpO2 only the 85%. So she transferred into the emergency respiratory department. And in the chest X-ray, we can see the brown glass infiltration increase again. So at that moment, as I show you in the previous slide, when the kids just had the symptoms, the chest X-ray, the lesion in the chest X-ray, or RCT again, when she reassumed the cow milk, that means we have the convincing Hainer syndrome. And in this patient, because the parents cannot understand the dangers of the using again the cow milk, so they give only 2 pickles and 5 teaspoons of the yogurt. And the symptom and the chest X-ray didn't have at that moment, but 1 day later, she just had the same symptom, and the chest X-ray looked like the 6 months previous. And at that moment, we give the patient the oxygen, the cannula, the cow milk avoidance again. And we must start the corticoid IV again, because the patients have the SpO2 only the 85%. And the chest X-ray, we see the round glass infiltration increase too much. So we need to give the patient a high dose of the corticoid IV in the 3 consecutive days. At that moment, convincing Hainer syndrome. So when we have the convincing Hainer syndrome, we don't need to maintain the high dose of the corticoid for the long time. At that moment, we can advise the parent to stop using the cow milk for the long time, maybe forever. Because when the kids using it again, the kids can have the same symptoms, the lesion, and sometimes it's dangerous for her. Next slide. So next slide. When we follow up the kids after 3 years and at that patients, when we decided to give only the corticoid and the taper very quickly, this is different from the IPH. In the IPH, we will try to use the 2 kinds of the immunodisruption, the corticoid and azathioprine, and we cannot taper the dose quickly, and we use the dose for the long time, maybe the 1 or 2 years. However, in Hainer syndrome, the corticoid, we just keep only 3 or 6 months to have the patient's condition become stable for the long time, and then the cow milk avoidance will be important. So we can see that after 6 months, we stop using the corticoid and only advise the parents to stop using the cow milk in this patient. And after 3 years, we can see at that moment, she's 6 years old, she no flares during 3 years, and with only the cow milk avoidance. And RCT, at that moment, the parent just asked us again, so what is the ideal time to have the patient to re-intake the cow milk? So we just advised her to admit it to the hospital again, and RCT to check her condition. We can see RCT, no lesion, no round glass opacity, no interstitial fibrosis, and in the CBC, the hemoglobin was normal. Next slide. The bone 4, this is considering the diagnosis of Hainer syndrome. Which of the following is a true statement? A, the positive cow milk recipients, IgG antibody, represent a pathognomonic feature. B, the cow milk allergy can be excluded in the children who are exclusively breastfed. C, control oral food challenge to cow milk after elimination is a good standard. And D, prognosis is very poor.
Please turn on the
So
microphone.
thank you. Okay, so for as we reach now the diagnosis of Hainer syndrome, I think it's the time to go over the possible pathophysiology and diagnosis and ultimately the prognosis later on. And I think it's good to go over the history and evolution of the diagnosis of Hainer syndrome. And this is a diagnosis linked to the first report of a collected cases by Dr. Hainer back in 1962. And there has been even an earlier publication in 1960 where first link between consumption and pulmonary manifestation. And then since then, case reports, very small and limited case reports has been reported. We will have one of the excellent case series or literature review on the topic. Now, since then, the manifestation of this syndrome has been quite non-specific and variable. The common thing is having a pulmonary manifestation with variable non-specific presentation, in addition to the association with anemia. Plus minus, in some occasions, other systemic manifestation, whether including GI, the commonest, or other system involvement. Now, one of the earliest reports and linking between the disease and possible underlying pathophysiology is linking this to the immune response in the multiple precipitants or specific IgG antibodies to the cow milk proteins. And so Professor or Dr. Hainer at that time reported the first report, and it was linked to his name. And he described it as a disease with poor growth in association with gastrointestinal symptoms in some cases, with some evidence of allergy, iron deficiency, anemia, and pulmonary hemosiderosis. Now, this is not straightforward, and maybe you have seen in one of the slides presented early in this grand round that in classical pulmonary references, pediatric pulmonology references, Hainer syndrome has been classified under non-immune diffuse alveolar hemorrhage, which might trigger you how come to be classified as non-immune when it is related to food, speculated food protein or cow's protein allergy. And I think it goes back to the exact pathophysiology, which is really, as we are going to see in the next slide, it is quite not definitive. And I think probably the reason why in classical references in pediatric pulmonology for the Hainer syndrome to be classified under non-immune is the fact that we knew earlier the other causes of diffuse alveolar hemorrhage, which is related to the autoimmunity and including the different auto antibodies, including the ANCA, the anti-good bastard basement membrane antibodies, and other autoimmune mediated manifestation. However, this syndrome, I think the confusion came that it is labeled as non-immune in relation to the autoimmunity. However, it is clearly that the pathophysiology is going and roaming around the external immune-mediated reaction to the cow's milk protein. Next. So, in looking to the case reports, this is the case, an excellent review in February 2024, where the cow's milk allergy, which is a more broad manifestation of the cow's milk reaction. Basically, as you can see in the reference, it is referenced in a pediatric gastroenterology literature. Most of the manifestation is related to gastrointestinal and cutaneous manifestation in the form of skin eczema. And there has been the least manifestation is the anaphylaxis and then the respiratory ranging from 1 to 8%. Given the fact this is related to very limitations in the literature where those cases has been characterized in variable ways, one of the important observation that there is 25% of the reports indicated there is an overlap between more than one system in such cases. Next. I would really advise you to go for, if you are interested in the subject, to go after this article published in 2021, where the authors have done an excellent work reviewing all the cases published over the past 60 years. They have reported almost 61 cases, and they did excellent work trying to study the diagnostic approach, and even trying to reflect on different epidemiological data. So as you can see, I know this is a busy slide. I would like to refer you to the original article. However, this is very useful. In general, most of those case reports over the past 60 years has been variable with very limited number of cases. The maximum publication had 22 cases. However, most of them got one case to less than 10 cases. And starting with the 1960 publication of Hainer himself, and the age in general was going in most of the case reports in less than 24 months. There has been few exceptions where the diagnosis has been up to 48 months. Actually, the oldest case report is in a child of 5 years, with all the limitation in the definitive diagnosis as presented in the early manifestation. Now, as you can see, I think one of the most important aspects in this review is that the diagnostic strength or validity has been questioned. And as the paper suggested, the first diagnostic approach, one of the major observation that the minority of case reports they reported and specified applying a challenge food test in their cases. Actually, there was only 6 cases out of 61 cases, less than 10%, where there was a confirmatory challenge test to confirm the diagnosis has been performed. Now, this is not to say this without the challenge and limitation of applying a food challenge test. Actually, most of the case reports where the challenge test has not been done was limited with the family and the parents concerned about exposing the child for a challenge test. On the other hand, there is a lack of protocol or standardized approach to be applied by physician in clinics for such food challenge test. Next. Now, I wouldn't go over the clinical manifestation. Most of those reports has come up with almost the same combination of clinical manifestation of respiratory symptoms, anemia, and diffuse radiological manifestation of alveolar infiltration. And some of them have been even complemented with histopathological diagnosis of lipid-laden and hemosiderin-laden macrophages in the lung biopsy. Next. The pathophysiology has been speculated with no definitive relationship that it could be related to the observations, where there has been variable observation, where there is increased titers of precipitants, likely IgG antibodies, like the one presented in our case, against the bovine milk proteins. Immune complex and cell-mediated reactions has been speculated. Some cases, not many, has positive skin test. Some of the cases has also shown increased serum total IgE levels with some specific milk IgE antibodies, which was lacking in our case. Some also reported increased circulating immune complexes and increased histamine profiles. Some of the cases has been also reporting aspiration of milk in association with the presentation, and some also has present with immune complex reaction confirmed in labs. Next. Now, I would like to take your attention that the precipitants, the IgG, the milk IgG, has been very famous in this syndrome. However, it's very important to mention that the causative relationship, the causation has not been proven and in a standardized prospective controlled studies. And so the relationship is not yet clarified whether it is an association or it is a causation. And this is driven by the fact that it is not pathognomonic for the disease. It is found in 1% of healthy children. It can be found in other chronic disorders like celiac disease, IgE deficiency, cystic fibrosis, Down syndrome, Wiskott-Aldrich syndrome, and Hurler syndrome. So we need to be really very cautious. It can support the diagnosis in the presence of other clinical manifestation. However, the presence or lack of those antibodies cannot be used to prove or exclude the diagnosis. Now, I would like also to take your attention to some of very interesting studies coming up with some hypotheses regarding the possible pathophysiology. One of the excellent papers came recently where a mice model has proven that exposing the early infant lungs to acidic milk regurgitated from the stomach make it more likely to have sensitization against milk protein. And that goes also to another hypothesis. There was an excellent study coming from Netherlands studying the effect of consumption of raw cow milk, where it showed protective effect in sensitization. And putting the two studies together, probably the manufacturing of cow's milk and the end product of the proteins, maybe it is more liable to cause the sensitization going through the immature junctions in the alveolar space, where those proteins can leak, and probably, this is a hypothesis, it can induce the sensitization, where in the breast feeding and raw cow milk, this manifestation is less likely. Now, I'm not proposing or advising for the ingestion of the raw milk, because we are aware of all the infectious risk related to consumption of raw milk. However, this is just in the discussion of the pathophysiology of this condition and why it is related to an evolving child. Now, next, please. As we are going to move to the next slide, there has been also one of the limiting factor in the diagnosis of this syndrome. Next is multiple fact making this diagnosis really challenging, where the high index has to be their high index of suspicion and your clinical judgment based on the deep and sharp history taking is going to make your major contribution to the diagnosis. And now this is difficult because in many occasions hemoptysis is very difficult to pick, especially in infant. They are not usually producing sputum, so having a child with anemia in infancy in the lack of hemoptysis cannot exclude pulmonary alveolar hemorrhage. So you have to have this index, high index of suspicion, and you might look for chest x-rays as a first screening if you have a child with unexplained anemia in combination with failure to thrive or even respiratory distress. Now, one of the things that also has raised a concern that there has been some observation of reports in Hehner syndrome where there was lack of direct exposure to the cow's milk and in children where exclusive breastfeeding was provided. And actually the speculation and the justification was coming from the maternal exposure to the cow's milk. So you have to be also looking for the possibility of either transmission of milk, cow's milk proteins through the breastfeeding, or at least, or even going further in the hypothesis that the IgG antibodies has been crossing placenta from the maternal system to the fetal maternal system. Now, one of the most important aspects, which I mentioned before, is the lack of controlled oral challenge of food of milk. And this has been really missing in many cases. And I think as we are going to talk later on, it is going to be the top tool to be considered if you are in need to confirm the diagnosis of Hehner syndrome. Next. Now, I think this has been touched before. Based on the recent publication where the 60 plus cases has been reviewed, I think this is probably the most important and most sensitive way to confirm the diagnosis. Now, we cannot use the term of confirming. We are using convincing because, again, it is not 100% confirmatory. You can compare the left side, which is the probable diagnosis of Hainer syndrome, where you have the clinical manifestation and the resolution of symptom after milk removal, the restriction of cow's milk. If you want to be in the convincing right side of the slide, you need to do recurrence of symptoms after milk reintroduction, which is the food challenge test, which can be done later on. Now, this is going to be really challenging and concerning because we are having a lack of protocol in this syndrome or cow's milk protocols. However, we will touch base on this later on. Next, please. So I think you can appreciate now that the detection of precipitant antibodies is going with the diagnosis. However, you need to remember that it is not pathognomic. The lack or presence of these antibodies cannot be 100%. Clinical improvement after milk removal is something you can apply. However, sometimes the lack of causal relationship in the history sometimes is there. Symptoms of reoccurrence after the milk reintroduction is the gold standard to confirm the diagnosis or make it convincing. However, as I mentioned, this challenge test is usually limited in clinical practice due to the concerns I mentioned before. Next. So I hope you have come across the differential diagnosis before. I think it's very important when you are dealing with diffuse alveolar hemorrhage to differentiate between the category of idiopathic pulmonary hemorrhage and the specific secondary cause of pulmonary hemorrhage related to the cow's milk sensitization. In the Hainer syndrome, the hemosiderosis is often, but not always. The GI symptoms is more prevalent compared to the idiopathic pulmonary hemorrhage. The precipitant is more likely to be there compared to the idiopathic pulmonary hemorrhage. The response to the diet restrictions is always supporting the Hainer syndrome in comparison to the idiopathic pulmonary hemorrhage. And the prognosis, and this is something was really vague before. However, I think the cumulative data now is indicating that the Hainer syndrome prognosis is good compared to the idiopathic pulmonary hemorrhage. And I think the earlier speculation that Hainer syndrome is a poor prognosis were due to the fact that there was a mix in the literature between the idiopathic pulmonary hemorrhage cases, especially the one related to the autoimmune conditions, where the prognosis is variable and sometimes poor compared to the Hainer syndrome. Next. So I would conclude my presentation with the treatment. I think the most important aspect of treatment is once you consider the diagnosis and it is convincing diagnosis, you have to move on to the formula or the food, the cow's milk restrictions. And here you need to apply probably if you have a clinical dietitian going to extensively hydrolyze protein, based protein synthesized free amino acids. And then you should have in few days a clinical improvement, and the radiological improvement usually will take more time to manifest. And now in the acute of using bronchodilator and systemic steroid, and I think there is not enough evidence to say this is something we can recommend. However, I think considering the stabilization phase of therapy and the lack of definitive diagnosis early in presentation, definitely the use of bronchodilator and steroid can be used as empirical therapy for kids presenting with respiratory distress and features of obstructive airway disease. And then based on the clinical assessment, you can decide whether you need to continue or not. This is for the bronchodilator. However, for the systemic steroids, it has been almost always used in the acute phase due to the fact I mentioned to you, because early in the stage, it is not definitive to be definitive diagnosis of the Hainer syndrome. syndrome. And on the other side, it's most of the time, it's the first line of therapy to stabilize the patient when you are handling patient with diffuse pulmonary hemorrhage. And then based on the definitive diagnosis, the length of the course can be defined. Now, we need to consider also the supportive measures, including iron supplementation for iron deficiency. In urgent cases like our case, you might need to give backed RBCs or blood transfusion. In severe or refractory cases, or probably the overlap cases where there is more of unclear persistence of symptoms, second lines of immune modulating or immune suppressive agent has been reported. However, I think this is not to be done by the first caregiver or pediatrician. I think these lines has to be provided by experts, and it needs to be done in referring centers. And this is definitely an area where consultation has to be made. Next. So I will handle the ball to the next speaker. Thank you so much.
Okay, the next slide, please. Okay, after 3 years of commute avoidance, the kids, the parents just asked the clinician to whether that their kids can re-intake the cow milk. So before we implement the oral challenge test, we will do the skin prick test with the cow milk again, and we check the specific ECG with the cow milk. And the reason why, because 3 years ago, the kids had the specific ECG with the cow milk negative and the skin prick test negative. Why we did it again? The reason is when the kids just avoid cow milk for the long time, and this can the cow milk, the protein of the cow milk can become the strain for the kids, and this can activate the EGG allergy. So before we implementing the our cow milk challenge test, we should check the skin prick test with the cow milk and the specific EGG. If they are negative, we will keep doing. The next slide. So we give the patients in the 3 days. The first day, only the 50 milliliter non-sugar, the cow milk, and 4 times a day. And in the day 2, we increase into the 100 and only 2 times. And in the day 3, increase the full dose of the cow milk. And this is 200. And we see that after the 7 days of the oral cow milk challenge test, during the time of do the oral cow milk challenge test, the patient just on in the emergency to see if they just have some symptoms on the chest X-ray, some infusion or lesions. We can give her some oxygen and some treatment. Luckily, after 7 days, the oral challenge test, chest X-ray normal, CBC was normal, and we follow up her in 2 weeks, in the first month, and every month, and until 1 year, and check the CBC again and normal.
So in terms of prognosis, as we mentioned before, early in infancy, it might take time for the diagnosis to be revealed. However, the good thing about the condition, it is reversible, as we have seen. And the reversibility is basically related to the dietary restriction with the positive immediate effect of the dietary restriction. So the prognosis is favorable with the restriction, and recovery should be anticipated in 5 to 21 days, clinically and radiologically later on. Opposing prognosis between idiopathic pulmonary hemorrhage and Henner syndrome is totally an important aspect, and we need to differentiate between the two items because the consequences, the prognosis, and even the therapeutic intervention are different. Now, also there has been some case reports of spontaneous tolerance to cow's milk, and probably this tolerance is related to the maturity of the junction between alveolar cells, and that probably it's just the maturity of the respiratory system, and so usually outgrow hypersensitivity, and they ultimately children can tolerate cow's milk within a few years in their life. Next. So as we presented earlier, the challenge, the controlled food challenge for cow's milk is a key component that it has to be done in a very controlled situation. And so, as I mentioned before, there is no specific protocols for the pulmonary hemorrhage related to the cow's milk or the Henner syndrome. This is a protocol adapted from the food protein induced enterocolitis syndrome in children, and it has been presented in our case in earlier slides. So in terms of accidental reactions to the milk, if there is accidental reaction, we have to avoid the challenge test and continue avoidance for another 12 to 18 months. If there is no accidental reaction with stability for at least 12 to 18 months, then we can perform the skin prick test and or serum level of food specific IgE antibody. And if it is negative, we can do the oral food challenge under physician supervision. And we have to have the controlled setting, which include having an IV access in place, doing baseline CBC, and doing the administration of challenge in 3 equal doses over intervals of 45 minutes. Now, if there is a positive prick test or specific serum IgE antibodies, then we have to consider delaying this till it is coming to equivocal or negative. Otherwise, we have to do it in more controlled situation. And if the test is showing negative with no symptoms after 4 to 6 hours, then we can add the food in an incremental fashion as described in our case. We will have it in the next slide. If it is positive with any symptoms, even if it's not specific, like emesis, lethargy, pallor, diarrhea, and if there is a recurrence or a change in the baseline labs, including neutrophil count elevation, then we have to continue the restrictions for another 12 to 18 months. Next. Now, this is again the protocol used for the cases of food protein-induced enterocolitis syndromes, and it has been proposed also to be applied in our situation. So I think going in an interval phased manner where you apply those restrictions, I think probably this is need to be done in a clinic where food challenge test is established, and having a specialist allergist where the setup to immediately react to reactions is available is of paramount importance. Next.
Thank you for the details and updated presentations by Professor Ananathan, Professor Yao Yao, Professor Sami and Heather, and Dr. Ho Ting Hương. Hopefully, we will gain valuable insights into pulmonary hemorrhage in children. Here are a few conclusions. I would like deficiency anemia with normal iron intake should prompt investigation for potential sources of bleeding. Pulmonary hemosiderosis is often associated with recurrent respiratory distress and anemia. Diagnosis is based on X-rays, bronchoscopy, and lung biopsy, with other causes carefully excluded. In preschool age children, Henner syndrome linked to cow's milk allergy should be considered. stopping cause meal and symptom recurrence upon introduction support the diagnosis. Follow-up with the control oral challenge is recommended to confirm remission. We are so sorry we have no time to Q&A, so we would like thank you sincerely for the active participation of the audience. And now I would like to invite Professor Sakin Ahmed to share a few words before we conclude today's session. Professor Sakin, please.
Thank you, Professor Dian. It's a great journey with excellent 5 guides, tour guides, I must say, Sami, Omdiem, and Ananathan. They really made us move excellently well. So in the next year, we'll be coming on 28th June, and this is 9 to 10 p.m. Hong Kong time. We'll be presenting by Bangladesh. There will be 2 cases will be presented, and one is a well-thriving 7-month child with cough, followed by fever with no history of foreign body aspiration. Another is recurrent and multiple skin abscesses in a 7-year-old girl with occasional cough. So the audience, which were about 180, and there was very little attrition till this time. Still, there are 159 is still attending. Thank you all for attending, and I'm inviting you for the next upcoming APPS conference in Thailand. So that is a big, great academic fest. You are invited. So let's go with the video, what is coming up. And with that, I conclude the session, and thank you very much. Thank you all.
Get ready for an experience you will never forget. These are 5 reasons you must attend the APPSDPRC 2025 in Bangkok, Thailand from April 1st to 4th. Reason 1. Premier Congress in Pediatric Pulmonology in Asia. This is Asia's leading congress in pediatric respiratory, critical care, and sleep medicine, hosted by APPS and TPRC. APPS has 22 member countries. It's your excellent chance to connect with the best in the field. Reason 2. Inspiring speakers and comprehensive program. Learn from renowned speakers coming from 18 countries. Attend 3 keynote lectures, 8 expert sessions, 20 symposiums, and from many symposiums designed to inspire and elevate your practice. Reason 3. Exclusive hands-on workshops. Dive into 2 pre-congress workshops and 10 complimentary workshops in the main congress, offering hands-on learning opportunities. Seats are limited. Don't miss your chance. Reason 4. Opportunities for recognition and awards. Submit your research abstracts to compete for the Young Investigator Awards and the prestigious APPS Young Fellowship Award. Reason 5. Explore Bangkok and enjoy Thai hospitality. Discover the rich culture of Bangkok, conveniently located at the Eastern Grand Hotel Phayat. Our venue is easily accessible and offers world-class amenities, including an international buffet at the Market Restaurant. Don't wait, mark your calendar for APPSDPRC 2025, April 1st to 4th in Bangkok. Visit our website for details and registration. We'll see you there. Looking forward to welcoming you in Bangkok.